Alrighty, so this is part B of aging for the nurse practitioner, focusing on primary care issues, but lots of other little things as well. As mentioned in the last talk, there is a fair amount of an issue with substance abuse and aging. In fact, a lot of this is going to be alcohol, but not all. And we can note that the numbers are seen to be growing. A few years ago, it was estimated at around 2 million. In another 3 or 4 years, it's expected to have grown to 4.4 million. So obviously, it's something to be concerned about. The number of folks that have used some kind of illicit substance is actually fairly substantial. Marijuana is becoming less of an illicit substance, but when this was being done, a number of folks were doing that even though it was illegal. And of course, the incidents between the 50 to 59-year-olds are higher than those 60 and older. Although as the baby boomers age, it's been kind of interesting to me that I am definitely seeing it in people 60 and above. In the folks that are admitted to places that receive public funding, which are the easiest statistics to get, which is unfortunately why there was a rumor going around that Maine had the highest incidence of narcotic abuse of any state in the country, when in fact it was probably about 23rd or 24th. That was being cited from a specific statistic that was related to public funding. But in fact, we can see that substance issues are substantially increasing over time. And alcohol is the most common substance that is abused. But as people are getting older and as other substances have been used when they were younger, the number of folks that are using other substances is increasing. The other thing, though, to think about in regards to this is the fact that way more elderly people are using prescribed drugs than younger folks. And many times these prescribed drugs are psychoactive. We're trying to decrease the use of benzodiazepines and other psychoactive drugs in the elderly. But I will be honest that there are a number of patients that their quality of life is just so much better if you give them a few benzos to address their anxiety, that we still definitely do prescribe those medicines to that age group. It's great for the idealistic people sitting in research centers to crow about how we need to get everybody off of these medicines, but the reality is when you have a patient sitting in front of you and nothing else seems to be working, and you have this option, it's really hard not to go ahead and use it. So again, we do prescribe probably way too many medicines for folks, and we should be trying as hard with geriatrics to get people off as we do to put them on. On the other hand, I'm all about quality of life, and if somebody is anxious and having a really poor quality of life, I think it's very reasonable to offer them some kind of medication therapy. Overdose deaths, I think, are actually kind of interesting, and I'm most interested by the fact that if you look at, going back. Sorry about that, I can't go back. But if you look at the number of folks that had overdose deaths, the incidence is way higher in folks with heroin. Prescription drug seems to be stable for the past 10 years or so. So I do think that we've kind of gotten a hold of the prescription drug issue. A lot of unintended consequences sort of makes us think that maybe more folks are starting to use heroin because of that, but I apologize. You can actually go back and freeze that slide if you're interested in looking at it more. So to go to Medicare, a lot of folks don't fully understand Medicare. It's especially hard when you've got the elderly that are trying to understand it to sign up for it. Medicare A is a benefit that is related to hospitalizations. It has a substantial deductible. The deductible is per episode. Last I looked, it was about $900. And so if you have someone who's admitted for congestive heart failure in February, that is considered an episode, and they will have to pay the first $900 or so of their hospitalization. And then if they're admitted in April for a fractured hip, that's considered a different episode because it's a different issue. They very well may have to pay the $900 again. So this is why it's important to have some kind of Medicare supplement for most people, just because they don't realize that Medicare is not going to cover everything, and that they will end up with bills for hundreds of dollars, not usually thousands, but hundreds. And it is frustrating for them when they do get those bills. Medicare B is basically office-based practice. Medicare B includes physician care, nurse practitioner care, physical therapist care, a number of different things. In the traditional Medicare B, it's usually a patient pays 20% and then the government pays 80%. Again, the amounts can be substantial if someone's going to a lot of appointments, and so all the more reason that many folks will get a Medicare supplement. Medicare C, which is not usually referred to as Medicare C, it's referred to as Medicare Advantage, is another alternative. Medicare Advantage is an aggressively managed Medicare program. Because of that, they can actually offer lower costs. The supplement that's provided to Medicare C from the government is actually greater than it is for many of the other Medicare programs. And so folks can end up with either no copays and no premiums, or very modest copays and modest premiums. Martin's Point Advantage program, the Generations program, is a common one around here that people are signed up for. In general, they get pretty reasonable care. If they need physical therapy, they're going to be very limited as far as the number of physical therapy visits they're going to be able to go to. They are somewhat limited by what specialists that they can go to, but especially someone of very modest means who wants all the basic care, can't afford a Medicare supplement, this may be a really reasonable alternative for them. Medicare D is actually the program for drugs or medications. It is a different Medicare program from either of the others. Usually someone signs up for A, B, and D, and then usually a Medicare supplement in addition to it. Medicare D, there's a number of different programs out there. They all have slightly different copays. They all have slightly different benefits. They all do, however, include the donut hole. So in a minute we'll talk about the donut hole, and that's something to really keep in mind in regards to these folks. So Medigap is what we used to call the Medicare supplements. Now they seem to be called Medicare supplements more often than they're called Medigap. So to talk a little bit more about Medicare D, or the drug program, there is prescription drug programs, and then the Medicare Advantage prescriptive drugs are actually included in that Medicare Advantage program. So again, it's something you need to be aware of when people go to sign up for a program. Is our medications included in that Medicare program, or is there some other issue? The premiums, deductibles, and copays vary, and as we noticed, there is the donut hole. The plan was to phase this out over 10 years under the Affordable Care Act. However, the question is whether or not the Affordable Care Act will be there in the future. And so we'll have to kind of see what happens with that. So the donut hole, as we note, is the space between the actual prescription drug program and catastrophic coverage. An example put out by one Medicare D program is this one. So step one is the annual deductible. In this case, it's a $400 deductible. It went up from $360 in 2016 to $400 in 2017. The prescription drug program expanded to now cover up to $3,700. So that's $3,300 of coverage, in which the member will pay their copay, and then the plan pays the rest. That did go up about $400. The coverage gap actually is still substantial. It's about $1,250. In that, in general, there's a limitation that patients only need to pay 40% of brand name drugs and 51% of generic drugs, but they will need to pay that full amount. They cannot be eligible for catastrophic coverage until they pay that full amount. Lots of times people start cutting back on their medications rather than actually paying that amount because they just don't have the money. And then catastrophic coverage kicks in after about $5,000 that has been spent on medications. You can see that about 12% of people reach the donut hole, and only about 4% of people actually make it up into catastrophic coverage. So there's 8% of the population that is just going to be in the donut hole and either be begging for samples or ask for generic drugs or other things during that time that will save them money. Medicaid is I think, a pretty misunderstood program because it is always a state program, but the vast majority of the funds come from the federal government. So even though the federal government will put stipulations on Medicaid, each state has the option of covering who they want to cover, having the level of coverage that they want, establishing the formularies that they want. And so I really notice I have patients from New Hampshire and patients from Maine. I think it's actually much easier to get on Medicaid in Maine, although I will tell you that the coverage is substantially better in New Hampshire for the folks that actually have gotten on. So it's a very challenging issue. A number of patients end up with Medicaid on top of their Medicare just because they don't have the ability to pay those other deductibles and things. So, all right, so back to the history and physical. Review of systems can be a very challenging thing for the elderly just because sometimes they have a lot of things. For me, it's circled because I give them a printed version of the review of systems and ask them to circle anything that they've experienced since the last time that we reviewed it. And if you have somebody and you have 50 things on your review of systems and they've circled 40 of them, then obviously that's very challenging to try to figure out where to start and what to do. So as I say, there's a number of ways to carry the review of systems out efficiently. I always have people circle. Therefore, I do feel like I can put all of those elements into my review of systems that I have reviewed them. I think you're going to find that a number of clinicians will include things on their review of systems, assuming that if the patient had them, they would have told them that. I think that's a dangerous assumption with any age, but especially with the elderly. So be careful and just make sure that you've got the appropriate documentation. When you review meds, obviously polypharmacy is a potential issue. There is no specific number of drugs that defines polypharmacy. So basically polypharmacy is when the patient's on multiple drugs and they're potentially interacting. So in general, there's lots of different statistics out there, but most people feel that if someone's on 5 or 6 drugs, they're going to have some interactions and they're going to have some implications of polypharmacy. You should be familiar with the Beers List. The Beers List was developed a number of years ago and has been revised a number of times. And basically it's a bunch of geriatricians that get together and review all of the different medications out there and make suggestions for what medications should be used, shouldn't be used, or should be used with certain cautions. I find it really helpful. If nothing else, it's got medical legal implications that if you're prescribing things that are on the Beers List, you're putting yourself at somewhat greater risk medically, or medical legally, I should say. So just be aware that it exists, look it up, and be familiar with it. Brown bag is a common technique in which you'll have people just bring all of their medicines in a brown bag. It usually includes herbals and supplements, and that way you can go back. Whenever I do this, I usually find that they've got 2 or 3 different bottles of the same medicine, sometimes labeled as generic, sometimes labeled as brand name, sometimes with different dosages. And we often have to throw some out or have them change some of those medications to really try to get them off it and get them on a more appropriate regime. With herbals and supplements, patients assume if something's labeled as natural that it has no side effects and it's basically harmless. I don't think any of us are really naive to think that that's true. Many natural things, including heroin and lots of other things, have great pharmacologic impact and need to be factored into interactions. Examples, of course, Coumadin interacts with all sorts of different things, but it interacts with ginkgo and a number of different other herbal medicines. So whenever anybody's on Coumadin and you're having a hard time managing their INR, we do have the option now to switch them over to a NOAC, a novel oral anticoagulant. However, you also need to consider whether or not they're using herbal medications along with their meds. Allergies, a number of folks have developed intolerances over the year and have named them allergies. Common one, a lot of these patients were allergic, quote unquote, to erythromycin because 40 years ago they took erythromycin and it made them sick to their stomach. In fact, 40 years ago, if you took erythromycin, almost everybody got sick to their stomach, and that's why they developed azithromycin and some of the other alternatives. So, you need to know what their reaction was. Our EMR actually does have the ability to label something as an intolerance or an actual true allergy, and you'll need to keep those things in mind in regards to prescribing. ADL scales, the CATS is the most common ADL scale. It includes the 6 most common activities of daily living: bathing, dressing, toileting, transfers, continence, and feeding. All of those seem really straightforward. The Hartford, the International Geriatrics group there, actually has some pretty good information on geriatrics gerontology on that website. But there's lots of other places that you can obtain the CAT scale, and it is pretty straightforward. When you're doing the physical exam, I think that in all ages the yield on the physical exam is pretty modest. Maybe slightly better in the elderly, but in general most of your evaluation is going to come from your history and then unfortunately from diagnostics and other things. To do the physical exam, you need to have time enough for the person to get into the positions that you need to do. Positioning issues. When you're scheduling people, we actually have 3 different types of exam tables on our floor that we can use. We have the basic one, which is the high one that everybody has to climb up on. We have one that's an adjustable one where it basically turns itself into a chair. And then we have some hill tables because we have osteopathic physicians who are doing manipulative therapy. Treatment. They hate it when you call it manipulative therapy. Depending on the person, you're going to schedule a room possibly, which does maximize your ability to examine the person. Screening tests will vary enormously, and I do have a whole nother talk on screening for the elderly, and we'll review exactly what will go on for that in that talk. You may actually have to have a longer visit to get the full history and do the physical exam on an older person. As noted, it may take 2 visits. You'll usually have to bill the second one as an episodic visit. Time of day, some folks do better in the morning, some folks do better in the afternoon, and if your scheduling staff can take that into consideration, you may actually get better information. The instrumental activities of daily living are also important to look at in regards to geriatrics. There's usually 8 of those. One is using the phone, one is shopping, one is preparing the food, housekeeping, laundry, getting around transportation-wise, handling the meds, and also handling finances. Finances can also be considered an executive function that we'll talk about in a little bit. But in general, you want to look at these things. If somebody's ADLs are fine, they're probably not going to have to go in a nursing home. But if their IADLs are impaired, they're definitely going to need assistance from the family. and or possibly assisted living. So that's usually the big difference between nursing home and assisted living. So to review on the physical exam what some of the findings of a normal aging can be, as we mentioned, the Achilles reflexes can be lost. Other reflexes may be decreased, but always do a differential diagnosis process. And ophthalmos, folks will actually start to lose some of the fat behind their eyes, and you will actually start to see some sinking of the eyes back into the head. Not a super common finding, but also not necessarily pathologic if you've got other laboratories and other findings that are suggesting that their dietary intake is adequate. Corneal arcus, what we used to call arcus senilis, is basically just a deposit of cholesterol around the outside of the iris. You'll see this fairly commonly if you look for it. A lot of people aren't necessarily even aware that they have it until a clinician points it out to them. It's really a benign finding. Even though it is cholesterol, it does not seem to be associated with hyperlipidemias or with any sort of risk of early cardiac death. But again, sometimes people have noticed it and they like to have it explained to them. Skin turgor, peripheral skin turgor is very difficult to evaluate. So if you have an elderly person and you're trying to assess for dehydration, you do not want to squeeze their arm and watch for tenting. Just because they lose a lot of the elastin in their skin, it's not going to bounce back the way that it should have, especially if that person's been a smoker. On the other hand, if you do it right over the middle of the forehead or on the middle of the sternum, you can get a reasonable assessment of skin turgor in elderly people, but as I say, don't be tempted to do it peripherally. Presbycusis is the phenomenon in which elderly people start to lose high-pitched tone abilities. So with presbycusis, they lose those high tones. Lots of times the louder you try to talk, the higher your pitch goes in your voice, and the harder it is for them to hear you. So in general, if you just talk in a lower pitch and maybe a little louder, but try not to yell, oftentimes elderly folks can hear you. This is why lots of times they can hear certain clinicians, but other clinicians, they just can't hear them. So respiratory rate, some people claim that it can go up to as much as 25 at rest. I'm a little cynical about that. I'm not convinced that that's true because I think that it probably reflects some kind of deconditioning or other issue, but it doesn't necessarily reflect heart failure or other issues that are truly pathologic. Orthostatic hypotension is going to be something that is actually very common as we age. As most of us know, the biggest reason we check orthostatic vital signs is to assess for dehydration. The thing with that is that in general, when you do orthostatic vital signs, you're going to have them lay down for at least 2 minutes and then check their blood pressure and their pulse. Then you have them sit up and then you wait 2 minutes and then you check their blood pressure and pulse again. Then you have them stand up, wait an additional 2 minutes, and then check their blood pressure and pulse. This gives the physiologic status time to equalize. If they're dehydrated, that 2 minutes will not make any difference at all. And they'll continue to have low blood pressures, 2 or 3 minutes later. There are patients who have sort of an autonomic instability in which they stand up quick and it takes a minute or so for their blood vessels to increase tone. Those folks will have normal orthostatic vital signs if you wait the 2 minutes, but if you check their blood pressure immediately on rising, they may have decreased. There's not really any official agreement that I can find on what makes somebody officially orthostatic. Most people say if their pulse goes up 20 or if their systolic blood pressure drops 20, they're orthostatic. I cannot find that anywhere in an official set of guidelines. The Emergency Nurses Association is as close as you're going to get. But just keep that in mind. There are things that can be done to help with orthostatic hypotension, mostly around, getting up slowly, make sure they're hydrated. If someone has an extreme case, sometimes we actually add a medication called fludrocortisone, and that often will help. The problem is that it's pretty easy to overshoot on that and have those people get hypertensive. So keep that in mind. The Fludro will actually drop their sodium levels raise their sodium levels and drop their potassium levels a little bit. So you also have to keep their electrolytes in mind. I have one lady now that I'm thinking I might want to try it on, but I can't seem to convince cardiology to try it. So we'll watch her a while longer. So hallux valgus, which is just a lateral deviation of the distal portion of the great toe, valgus meaning lateral, is very common when that bony area and that first MTP joint overgrows. That is a bunion. And so if somebody develops a bunion, if it is big enough and problematic enough, it needs to be repaired. They straighten the toe, they remove that excess overgrowth, and it makes it much easier for those folks as far as wearing shoes and having, normal foot function. Not done all that often, but in some patients it can actually be pretty helpful as far as improving their ambulatory stability. Other physical exam that you might want to familiarize yourself with if you're going to be taking care of institutionalized elderly are the cortical release reflex. So if you tap their lips, they purse their lips. They have a sucking reflex. They have a palmo-mental reflex, in which if you stroke the thenar eminence proximally to distally, their chin will twitch, as well as really being familiar with the Babinski reflexes, because normally there are no Babinskis present except in young babies and people with very advanced stage Alzheimer's disease. So, as I say, that's an abnormal neurologic finding which can happen in these folks, and you should be somewhat aware of that. Gynecological care, we'll talk about screening guidelines when we talk about that. Oftentimes in women over 65, if they've had a hysterectomy, there's not necessarily a need to do a pelvic exam, although that is controversial. There's different recommendations. The American College of Physicians says no. The gynecology group, ACOG, says that they should have a pelvic exam to check anyways. Basically, it comes down to the clinician reviewing what the currently extant guidelines are and making a decision in collaboration with that individual patient, depending on the risk and benefit. I have a number of elderly women who choose me because they know that I will not insist on them having a pelvic exam, although I do very clearly, document the fact that we discuss the advantages and disadvantages and that they've opted not to do that. Labs and diagnostics, again, I'm not going to talk particularly at length in regards to that in this talk, but just a couple of points. One is that anything you order for labs should really be based on what you found in your physical exam and history. So that's especially important because if you try to attach a lab to a physical E&M evaluation and management code for an elderly person, Medicare will not pay for it. They have some that are called screening for lipoid disorder that they will pay for once every 5 years as a screening. But it has to be attached to that ICD-10 code. It cannot be attached to the physical E&M code. So just something to think about in regards to ordering laboratories. So when you're doing your differential diagnosis in an elderly person, you're going to keep in mind what are the issues that are common in this age group. You're obviously going to keep in mind the fact that there may be altered presentation. UTIs can present with confusion, they can present with malaise, they can present with fatigue, often are very difficult to diagnose and are a good way to fix someone's delirium if they are delirious, but you just need to keep that in mind. Pneumonia, again, is often a hard thing to diagnose. Remembering that chest x-ray may be normal in an elderly patient with pneumonia if they're dehydrated at all. So when you do that evaluation, you're going to want to probably hydrate them before you check that chest x-ray. And so remembering that pneumonia is a clinical diagnosis and may be made even in the presence of a normal chest x-ray. If you have that patient that's maybe a little bit febrile, has areas of consolidation, and you really do have evidence that they have pneumonia, you can make a diagnosis even with a normal chest x-ray. So I use bronchophony a lot in these folks to try to decide if they've got areas of consolidation. I don't use egophony very much, but it is also a very useful technique to try to delineate whether someone has consolidation in an area. But at any rate, this is a place where your physical exam skills can really come in handy, and you should be very aware of that. Other atypical presentations, people that are hyperthyroid will often present as apathetic. They just are so overtired from their heart racing and all those other kinds of things that they just lose all their energy and they just feel apathetic. When people are hypothyroid, they may just feel very mildly weak. They may have mild constipation. They may have mild thinning of their hair. All of things a lot of people attribute to normal aging. This is why we often screen elderly women, especially for thyroid issues. Plain TSH is probably enough to do that, but if you add an additional test, it should be the free T4 rather than the regular T4, just because it is a bit more sensitive for that kind of thing. Bowel infarct can be a really ominous thing to happen to an elderly person. It is something that is a pretty hard diagnosis to make, much easier now that we do CAT scans more often, but this person may be confused and just not feeling good. And again, if you've got someone with these acute symptoms, especially if you're in an emergency setting, getting an abdominal CAT scan, and of course you usually want to order abdominal and pelvis almost always, is going to be useful. As we noted, altered presentation of heart attack. They'll be sweaty, they may be short of breath, they might have epigastric distress, they may just feel dizzy. Syncope is something, of course, that's different than dizzy, because syncope infers actual loss of consciousness. So if someone's just feeling dizzy, they don't have syncope, they actually have to have passed out. Near syncope, of course, is nearly passing out. So it is a term that you need to be very familiar with. Syncope has its own evaluation. Dr. Carpenter will be talking about evaluation of syncope later on in the semester, but it is something you need to be familiar with and really have a good sense of the differential diagnosis. They may just feel weak, they may throw up, they may feel confused. Again, this is why when someone goes into the emergency room with acute symptoms, they'll often do troponins just to rule in or rule out an MI. So as we say, sort of as far as ADLs and functional abilities, there's sort of three levels: the basic ADLs, the instrumental ADLs, and then executive function is sort of that top level. And that's the ability to plan, organize, initiate, be future-oriented. And there's not as much for tools in evaluating this, but this is one of those things that I think you probably will know it when you see it. So just keep that in mind. Depression, one of the things to really think about is that we often equate depression with sadness. And the thing about that is that in the elderly, they often won't feel sadness per se. They'll feel apathy, they'll feel discouraged, they'll feel other things, but they won't necessarily have sadness per se. So when you ask them if they're depressed, they'll say no. But if you use an actual tool, we pretty much are required to use the PHQ-2 in regards to meaningful use at this point. And if there's any abnormalities on the PHQ-2, in general, most people reflex to the PHQ-9, which is a reasonable test. There is also the geriatric depression scale, which has a, I believe it has a 10 item version, 15 item version, and 30 item version, which is considered to be a bit more sensitive for the elderly. So if you weren't picking something up, but you really felt like there was still something there, that's another option to do the GDS. They also call that the Yes-Savage scale. Safety evaluation, again, it's great if someone can actually get into the home, but if you can have either questionnaires or ask them questions about whether or not they have smoke alarms, carbon monoxide detectors, whether their lighting is adequate, whether they use throw rugs, any of all of those things can potentially save a life or a fall. So we're going to talk now a little bit about culture, and I think it's really hard to talk about culture in a state which really does not have particularly diverse culture. And one of the things that I think is pretty impressive is that when you look at nationally, we can see that the growth in the population over 65, the majority is going to be in Latinas and Latinos. It's going to be in Asians. We are going to see a higher growth amongst African Americans and American Indians than we do among white folk. So no matter what, you're going to be seeing increased numbers of these folks. The reality is, however, that in Maine, right now, and I haven't looked it up in a little while, but as of 10 years or so ago, there was 0.5% black folks in Maine. So the African American population in Maine has grown some, but it's still not dramatic. The other thing to think about in regards to that is that having a culture is very different if you are a very small number of people in an overarching culture, as opposed to being in a place where there are communities and neighborhoods for each individual culture. So I think that it's really easy, if you are from a place that really doesn't have a lot of different cultures, to believe that you are doing well in regards to culture. A lot of folks, when I grew up in New Hampshire, they're, I treat everybody the same. Well, the problem with that is that different cultures have different standards for the way that people should be treated. So you're being very culturally incompetent if you are treating everybody the same. You need to keep in fact that in certain cultures, certain things are acceptable, and in other cultures, it's not. So there is a woman that's done a fair amount of writing on this. Her name is Kapina Bakode. She's really kind of classified everyone as being either consciously competent, consciously incompetent, unconsciously competent, or unconsciously incompetent. So the majority of folks, I think, in our area are either unconsciously incompetent or consciously incompetent. And I do think that being consciously incompetent is far and ahead the better way to be. I'm very aware that if I have someone from another culture, that I am not particularly aware of what the rules are as far as eye contact, as far as when it's appropriate to touch, whether gender issues are handled in a certain way. So as I say, it is something that I think as cultures increase, we're going to become way more aware of. Right now, there does seem to be a little more xenophobia in the country than there has been at times in the past, especially in relation to Muslims. But I do think that we need to take care of all patients and treat them all with respect and dignity. And so, I think that we need to become progressively at that. So, one example is the hand gesture. If I'm putting my thumb and index finger together and making a little circle and my other three fingers are splayed out, that's the A-OK. However, if you're in Southern Europe or in South America, that is basically telling someone that they are an a-hole. That means something very, very different, doesn't it? So you need to be very aware of what's going on. We're fortunate that we do have ability to get interpreters in our office, almost always by phone, actually. So we do call ahead. The interpreter will, will be there on the phone and will interpret for us. Obviously, if you have a interpreter in person, they can pick up on other cues, but at least having an interpreter can be really, really useful. I would highly discourage you from using family members as interpreters. The problem is that in certain cultures, family members are not necessarily going to tell you exactly what the person said because it works to their advantage. So, you really should have someone independent. The other thing is that family members do not necessarily know all the medical terms and are not trained folks to interpret the concepts into the language of the person. So, as I say, it is an issue that is fraught with risks if you use family members. I mean, I've done it if you kind of have no choice and you're in a walk-in or ER setting, and it takes a long time to get an interpreter on the phone, and it's a very straightforward thing. I think that's probably okay, but for anything that's like ongoing and anything that would be sensitive at all, I would highly encourage you to obtain an interpreter. The folks in different cultures question authority at different levels. Some basically take the clinician's word as gospel and try to do exactly that. Other cultures listen very carefully and will never question the authority of the individual instructing them, but then go home and do absolutely nothing that they were asked to do because they do not believe it, they have not bought into it. So, you have to be very careful. There's varying levels of validity of the mechanisms that we use to communicate with those folks. To talk specifically about some cultures and also to use some of these cultures as examples of particular things. African Americans, one of the challenges is that they're a very heterogeneous group. There's African Americans that grew up in the North, that grew up in the South, there's Democrats, there's Republicans, there's all different kinds of folks that are African American. They do share some elements of a shared experience. They do sometimes have similar ideas, but again, you constantly want to be validating and questioning any of your assumptions when it comes to stereotypes. There's a reason that stereotypes exist, but there's always exception to those stereotypes, and you need to be aware of that as well. Many African Americans are very skeptical about the American medical system because of the Tuskegee experiment. Back in the early 1900s, there was a experiment that was started that was trying to look at the natural history of the disease syphilis. They had a group that they were watching. Once the treatment for syphilis came out, which was penicillin, which was a pretty effective and very thorough treatment, in the infinite wisdom of certain people in the United States federal government, they thought, oh, wouldn't it be great if we actually looked at some folks that were treated and some folks that weren't treated. And so they randomized people at the Tuskegee Institute in the South, I believe it's in Alabama, to either receive or not receive the treatment. So basically they withheld treatment from a number of African Americans without their consent, without their knowledge, and basically just tried to watch them to see what would happen. It's pretty clear that they probably would not have done that with a population of Caucasians. So African Americans have been somewhat skeptical in regards to that since. It is interesting because there are certain sociological elements as well. African Americans are less likely to be in nursing homes. They do tend to have stronger family units, although unfortunately related usually to drug issues, more and more African American men are being incarcerated. But hopefully they'll address that before too long. There are lower suicide rates among African Americans, which is really kind of a counterintuitive finding, just because you usually find higher suicide rates in people that are disadvantaged or poorer. It does seem to be related to the strong faith that most African Americans have, but they have not really exactly been able to explain that lower suicide rate sociologically. African Americans are twice as likely to be poor, but there's also very affluent African Americans. 7% are college educated, which is a bit lower than Caucasians, but is actually growing substantially and growing faster than Caucasians, although it is still well behind. And it's an interesting question whether affirmative action is an appropriate response to this, but I think with the much lower rate of college educated, I think that is something that does have a certain logic to it. Hypertension is higher, and it's interesting because it does seem to be different. This is very sensitive when talking to African Americans because they don't like being treated differently than Caucasians, understandably so. However, there does seem to be a difference in regards to the way that they respond to ACE inhibitors. They don't seem to respond and have the benefits that Caucasians do. They seem to do better with amlodipine and some of the other medications. And so, be very aware for JNC8, what those recommendations are, and also keep that in mind. John Henryism is basically, John Henry was a guy that worked on the railroad and basically worked so hard that he ended up having a stroke and dying. And you definitely see this phenomenon, to be honest with you, in all middle-aged men. They're like, I don't need treatment for my blood pressure. I don't need cholesterol medicine. I don't need any of these things. But you definitely see it in African Americans as well. These men are very proud individuals. They're trying to work hard. They're trying to provide for their family, and they will continue to work and ignore their own health care. Prostate cancer, for whatever reason, probably a genetic issue, is substantially higher in African Americans. To be honest with you, I don't always do screening in Caucasian patients based on the USPSTF review as well as a number of other reviews. I do think that because the incidence is high enough in African Americans that one should probably think about maybe doing screening like one would as if one had a strong family history. So if someone has, their father, their brother, whatever, had prostate cancer, I tend to lean towards suggesting screening. If someone has never had any prostate cancer in their family, if they don't have any risk factors, if they don't have any symptoms, then I think that the potential risks probably do outweigh the potential benefits as far as doing PSAs. I don't ever think that there's probably a role for digital rectal exam, although there definitely are still people doing that, and it's not wrong to do that, but just keep, be aware of what the research says. Glaucoma is a bit more prevalent, so I always do nag my African American patients to make sure to get in and have their annual eye exams. A bit lower risk of hip fracture. On average, African Americans have a little bit higher bone density, but I'm not sure that there's really anything different than we can or should do about that. The crossover phenomenon is the fact that in general African Americans have higher death rates until age 80, and then after age 80 their death rates are substantially lower than other ethnic groups. Churches are more active, so there is more social support for many African Americans, although I can't generalize to all. Prostate cancer, this really just demonstrates that African Americans do have a much higher rate White folks have the next highest rate, and you can see that the American Indians and Alaskan Natives have the lowest, closer to the Asian and Pacific Islander rate. So, again, in an Asian, I think it's less important to get any sort of screening. In an African American, it probably is important. In a white person, the jury is still out. I think there's more evidence against screening than there is for it, but it really is one of those things that individuals have to make a call. So again, reviewing the American Indians and Alaskan Natives, there's 558 different tribes, all of whom are really pretty different. We can generalize about American Indians in a sense. There used to be a general feeling that they had a higher alcoholism rate. That seems to be true amongst some tribes, but not amongst all. They might even have a slightly lower rate of Alzheimer's disease than do Caucasians. They definitely have a lower suicide rate among the elderly, and we all know that the elderly is the highest suicide rate amongst most populations. And the other thing is that they do have traditional healers that they often will go to, either as a supplement or as an alternative to Western medicine. So actually, it's kind of an irony to call it Western medicine, isn't it, when we talk about the American Indians? But at any rate, as an alternative to, American traditional medicine. Latinos, it is interesting. East of the Mississippi, we often refer to them as Hispanics. West of the Mississippi, they always refer to them as Latinos, women being Latinas. There's no real importance to this. The feds tend to put them all together either under the term of Hispanic or Latino, depending on the agency. They're also very heterogeneous groups. My daughter teaches in Chelsea, Massachusetts. A few years ago, she had 23 students in her class, 17 of which scheduled conferences the parents did with her, and she needed 9 different translators. Now, in fact, of those 9 different translators, at least 6 or 7 of them were actually Latinos, but some were of different countries. So there was Nicaraguan Spanish and Honduras Spanish and Puerto Rican Spanish, and there often is enough difference amongst those folks that it is really hard to generalize. On average, when we put Hispanics together, they do have a increased rate of obesity and type 2 diabetes, maybe just related to diet change for them, but does seem to be a major issue. They do have higher depression than do Caucasians or African Americans. The geriatric depression scale seems not to be quite as good for that. Latinos, on average, have had higher cervical cancer rates. Obviously, that can change over time related to behavior, but I would definitely be aggressive with all of my teenage girls and boys to make sure that they get their Gardasil. But in the Latino population, you might want to even be a little bit more aggressive. There definitely seems to be progressive xenophobia, which xenophobia is just fear of immigrants. For the Latinos, it's actually very interesting because after the Mexican Revolution in 1910, there was more and more Mexicans that came into the country to pick fruit and to basically be migrant farm workers. In the 1940s, we very much supported this. There are a lot of folks away at World War II. There are not enough people to maintain the agricultural needs of the United States. And so the braceros were groups of Mexicans that came over the border in the 1940s and were very aggressive workers, hard workers, and really basically saved America's bacon, if you will, by providing all sorts of agricultural support. Other groups, the Puerto Ricans, even though We think of them as Latinos. They're clearly not immigrants because they are born in America, because Puerto Rico is an American territory. So all of the Puerto Ricans that have come here do not need passports. They do not need green cards. They are born American. And there was actually in the 1980s, there was a group of Puerto Rican nurses that were brought related to a severe nursing shortage. It did seem to help in the areas in which Spanish language was common. Unfortunately, they tried to use them in Boston when I was there, and it was kind of hard to communicate with those folks. But Puerto Rico became part of the United States after the Spanish-American War in 1898, of course. Cubans, on average, are older and more highly educated. It will be interesting to see now that Cuba has opened up a little bit if there will be more immigration from Cuba. It'll also be very interesting to see with the new administration how they sort of handle that whole thing. So I guess we'll just have to wait and see on that one. So the other thing that happens with Latinos is they've often been in a country in which they just went in and bought amoxicillin in the pharmacy and didn't have to go to see a provider, didn't have to have it prescribed. So a number of different Latin American countries, including Spain itself, so many Spanish-speaking countries, prescriptions are actually over the counter. It is interesting because the antibiotic resistance rates in those countries are slightly higher, but very slightly higher, like 0.2%. So it is an interesting question, and maybe an argument that we maybe shouldn't be quite as worried about antibiotic resistance as we are when you've got a country here where we're trying to restrict all sorts of people from getting antibiotics versus the folks that can just go in and buy them over the counter. Asians and Pacific Islanders, very heterogeneous group. I don't even know that we can classify them as having a single culture. China itself, has billions of people in it and has a number of different cultures within it. There's, 2 major languages, but a dozen different languages. Mandarin is the most common language, but the folks in, other parts of the country speak different languages. In fact, Hong Kong speaks a totally different language than mainland China. India is also a huge country, a number of different states. If someone is from Uttar Pradesh, it's very different than if they're from, way down at the tip of India near Mumbai. They're going to have a very different culture. Many of them, the national language of India is Hindi, and most people do speak some Hindi, and many of them also speak some English after having been an English colony for so long. But it is enormously variable. Most folks from India are Hindu, but I've known Muslims, I've known Christians, I've known all sorts of different people. So Pakistan is actually a country that is almost universally Muslim, though. Pakistan used to be part of India and broke off to become, more of a Muslim state. It was 2 parts. Pakistan used to be in the north and the south, and then they actually broke Bangladesh off as yet another country. Although Bangladesh is extremely poor and is a very challenging place to live. Japan, again, Japanese culture is very different than Chinese or any other culture. Southeast Asian, even within Southeast Asia, there's the Hmong. There's the Vietnamese, there's the Cambodians who speak Khmer, lots of different things. There is somewhat similarity in that they often will do more traditional treatments such as coining, such as cupping, such as those kinds of things. But you just have to be really careful trying to generalize to all of those folks. As noted, Southeast Asia, number of different countries, which have a number of different cultures. Some of the folks, we have a number of folks here in the United States and even in Maine that came over after the Vietnam War. They came in the mid to late 70s after we lost the Vietnam War. Many folks from Vietnam that had supported the Americans really had no choice but to leave, and we tried to bring many of them over here. A number of folks from Cambodia came over in the late 70s related to Pol Pot and the killing fields. There's just a great control of the intelligentsia and large numbers of deaths and control. But there's also folks from Laos, there's folks from the Hmong. The Hmong, lots of, did also support the United States in the Vietnam War, so many of those were brought over. There was a 50-state plan where they were trying to put all of these folks in all 50 states. The later waves of Southeast Asian immigrants tended to be located together so that they would have a community of their own and would have some support. But the earlier programs tried to put a family or two here and there. So here in Sanford, where I am right now, we have 10 or 15 different Vietnamese and Cambodian families, all pretty much very successful, hard workers. But the younger generation, most of them don't speak the native languages, don't follow the native traditions. They've been very much Americanized. Obviously, in those places, the life expectancy was low. If you want to get a little sense of Hmong culture, I'm sure some of you are familiar with the book "If the Spirit Catches You" by Fadiman, which is basically about a person that has a seizure disorder, but is felt to be a spiritual issue by the Hmong. We talked about the coining and cupping. They also use betel nut. And one of the other phenomenons that I'm always very aware of is I have a number of Vietnamese and Cambodian patients. And what they often will do is nod very politely and say yes, yes, yes. And then when they come back in, they either haven't taken the medicine or they've taken half the dose, just because they are very concerned about how strong Western medicines are and are very hesitant to actually take those dosages. The folks from Southeast Asia, again, I've found them to be very hardworking folks. They were more poor here in the United States. They were linguistically isolated. The older generation is still somewhat, although almost always they have kids that can translate for them as far as the basic things. I have a number of Cambodian and Vietnamese families, and I found it interesting because the Vietnamese families almost all now go back to Vietnam for the winter, just because it's a much better environment for them. They like it over there, but they do try to maintain their connections here in the United States with their families. So, Southeast Asians, there's lots of Buddhists, there's some Hindus, there's also a lot of Catholic Vietnamese as well, though. On average, they had higher smoking rates. I think that's getting somewhat better. The older generation obviously has some PTSD associated with what happened, with the killing fields and with different things. And folks like that may also have somewhat higher osteoporosis rates. In general, in thin people, you're going to see a lot more osteoporosis. So, again, I'm not a huge proponent of doing a lot of bone densities, but, if you have somebody who is of that age group and is rather thin, probably not a bad idea to do that. At the very least, you can encourage them to be doing weight-bearing exercises. Alternatively, we can talk about the bisphosphonates and other treatments, but I personally think they have a relatively modest effect and some fairly major side effects. So I try to allow patients to make the choice themselves, but I am pretty careful recommending those. So this completes Part B. This is the basic assessment. The next talk is actually going to be the geriatric giants, that talks about 4 or 5 of the common pathologies amongst geriatrics, which is where geriatricians really kind of provide their greatest benefit. And we'll talk about that in the next talk.